Welcome everyone. Have you all got enough food to eat? Yes, plenty. There'll be plenty left over by the looks of it. My name's Anthony Caiafa. I work at North Coast Veterinary Specialist Referral Centre in the dentistry area. I also lecture at James Cook University in Townsville to the undergraduate vet students. I am a veterinarian and also a human dentist as well, so I work in human dentistry still. We're going to go through what is a cohat. Now, when I put this title up, then I thought, does anyone know what a cohat is actually? So we might go through what it is. So we'll see if our next slide comes up. That's good. It stands for Comprehensive Oral Health Assessment and Treatment. So that's what it stands for. What it does mean is that you have to do an oral examination, which includes extra-oral and intraoral. You need to periodontal probe. You need to take dental radiographs and all that, and chart that, and that should all be performed under a general anaesthetic. That's the whole idea of doing a thorough oral examination. You can't do that on a conscious animal. You can do some things on a conscious animal, but if you want to do a thorough oral examination, you have to do that on an animal under GA. Now, do you all have dental radiography capability in your practices? No. Okay. So maybe you should talk to whoever, the people with the money. It's on your wish list. Okay, I'll put up some slides here that you will wonder why you don't have dental radiographs. Okay. I was lucky enough to work a little while in South Africa. So that's yes, so that's my bald head. So this is a rescue animal. So why is there a tiger in South Africa, you're wondering? Because they're not native to South Africa, but the place I worked at rescued lions and tigers from all over the world, from zoos, from circuses and things like that. And as you can see, a lot of them are cage biters because of boredom, and they're stuck in cages, so they break their canines and they need root canals. So we perform lots of root canals on these guys. They act like little cats as well, in that they're very susceptible to acute renal failure, so you can't have them under anaesthetic for a long period of time. And so the anaesthetist, who you'll see later on, does everything, bloods, full whole body assessment, and we're doing the intraoral exam. So what's involved? So when we do an oral examination, it's split up into conscious and then under GA. So what do we do in a conscious exam? So normally you should examine the whole body. So a whole body examination, and then for the extraoral areas of the head and neck, you will look at the muscles of mastication, which basically are muscles that help the animal chew. So mastication meaning chewing, and also they're the muscles that close the mouth. Then we looked at draining lymph nodes. So the main one you're going to feel is the mandibular lymph node. The others are not easy to palpate. They're more in the neck area or covered by a lot of tissue, so they're not easy to palpate. We also, as nurses, you should be looking at these animals front on and looking for any asymmetries. So is there swelling on one side, or is there some atrophy? That's an important thing, and that's what I do when we look at them to see in the conscious exam, is there something that's asymmetrical? You can also palpate the bones that of the upper and lower jaws. You can also easily check temporomandibular joint function. So that just means opening the mouth. You'll see in my conscious exam, I get a bit carried away with that. Malocclusion means there's an abnormal bite, so you can also check that. Obviously, if the animal won't let you, can't get near it, It's Cujo and it's a Rottweiler and it's a guard dog. You're not going to get near it. So obviously pick the animals that you can do these sorts of things with. You can also look, not in detail, but you can look at the soft tissues, and we'll go through what this sort of exam looks like. Firstly, you've got to understand what normal occlusion is. So there is a website called the American Veterinary Dental College.org website that goes through lots of things, and in that it includes occlusion. So if you look at the top one, that's considered normal occlusion. If you look at the one on the left side, that's a class 2 malocclusion. So I don't know if you're seeing a lot of cavoodle things at the moment, but a number of them will have class 2 malocclusions. And when they have that, the mandible is shorter than the maxilla, the upper jaw is longer than the lower jaw. So some people will call it a overbite situation. And sometimes these lower canines start to hit the hard palate or the roof of the mouth. So that can be a big problem. If you look at a class 3 malocclusion, it's the reverse of the class 2. So the mandible's too long and the maxilla's too short. So you get that situation. Now that can be quite normal in an English bulldog, some staffies. So it can be quite normal in certain breeds, in boxers as well. So they have something called pinking shear. So pinking shear is where the premolar teeth interdigitate. So they're for grasping and shredding. You know, remember dogs come from wild dogs, so for prey, to grasp the prey and to shred the prey up. Sorry, my mouse is not working very well. So if you took notice of the previous slide, what malocclusion does this puppy have, do you think? This is the interactive. Overbite. Okay, so that's called a class 2 malocclusion. So that's something you need to record on the file. And even would you say that's severe or moderate or mild? Severe, because the mandibular canines are behind the maxillary canines. So it is quite severe. Now sometimes these dogs will hit the hard palate in this area rather than this area. So there's a lot of misinformation out there about using rubber balls. Rubber balls won't work very well for that. And rubber balls won't work very well if that tooth looking side on is in line with that tooth, because rubber balls can only move teeth if there's a place for them to go. Sorry. Okay, so what about this? What is going on here? So we've got a puppy, that's an adult, that's a permanent tooth, permanent tooth, permanent tooth, permanent tooth. What's that? It's a baby tooth, deciduous tooth. And you may not be able to see it, but you can see it here. What's that behind it? So that's the adult permanent canine tooth. So what's stopping that from getting into the right place? That. Okay? Now, there is another problem here. And that problem is, if that's the mandibular first molar, and I can tell you that dogs should have 4 premolars in each quadrant, then that's the 4th premolar, the 3rd premolar, 2nd premolar. They're missing the 1st premolar. Which, is that a problem? Would you go looking for that? I would. It can be a big problem. And I'll show you what a big problem it can be. So that's the missing premolar 1. And the other one, that's the canine, which will be, if nothing's done about that, and you've got to do it straight away, nothing's done about that baby tooth, deciduous tooth, that tooth's going to hit the hard palate. So here we have a situation where that mandibular first premolar wasn't extracted, wasn't found and wasn't taken out. So this is a 6-year-old dog. I don't know if you can see that, but there's a huge hole in its front part of its jaw there. And you may not be able to see, but there's a little tooth still there. and it's the same on the other side. And I'll see if this will play, because, so this is like a screenshot of this dog. So you can see CT, transverse view. I'll point out, so this is the left side. So you'll start to see, there's a canine, you'll start to see that hole there, see that hole there? That's in the jaw. And you can see another hole there, and that hole's still there, it's still there, still there, still there, and it corresponds to that. So these dogs can break their jaws, and we have seen it happen. So if someone had noticed a little earlier that that guy had a missing premolar 1 and you took an x-ray and you saw it, you could take it out at 6-7 months of age rather than let the dog get to 6 years of age and get a dentigerous cyst. So this is a surgery. You can see we've had to take out the canine and all the premolar teeth to uncover the cyst so we could actually see it. And then we curette it out, and then we basically put a bone grafting material in there, and we mix it with the dog's, we spin the dog's blood down and at 3,000 RPM for 10 minutes in a centrifuge. And the middle fraction of that spun down blood is called platelet-rich fraction, and we mix the platelet-rich fraction with the synergy, which is the bone grafting material. So that's about 5 vials of bone grafting material in there, and we could have put more. And this is the dog 6 months post this surgery. There it is there. You can see it's all looking pretty healthy, and that's the bone fill at 6 months post-surgery. So the vet sent me those photographs and radiograph from when they looked at it again in 6 months.
This guy is 10 years of age, so we'll start from caudal to rostrum. So we'll just check parotid salami glands, which are U-shaped just underneath the base of the ears. We'll work our way forward, and we'll just palpate the lymph node, which feels normal in this guy. Then we'll do a soft tissue exam, so we'll look at temporalis muscles, masseter muscles. Birds will check when we open and close his mouth. And we'll just look for symmetry, facial symmetry, so no swelling. We can also check the maxillary bone. We can also check the mandible, the mandibular bone, just by feeling here, and on the side. Okay. And the other thing we can do is just check the occlusion. Now it's a bit hard in this case because he's missing his canines. So. But he looks like he probably would have been a class 2 non-occlusion because his lower jaw is shorter than the upper jaw. He's got a few missing teeth, as we can see. So with the conscious exam, we can't really do a very thorough oral examination, but we can just have a look at how much calculus he's got. He's got a fair bit of calculus, so we'll probably say 2+ to 3+ calculus score. And the other thing we can check, so we'll just have a look on the other side, so it's been quite good. He's missing his canine on the other side. He's missing a premolar 1 by the looks of it. Again, calculus, so pretty even on both sides. He's got a fractured tooth here, which you can see. Also just check TMJ function.
I got a bit carried away there. So
that's pretty good. He's got the mouth opening as well.
Yeah.
Okay.
Very good dog. Pick a good dog to do it on. Okay, so as nurses, the first thing so do you guys do the oral exam, the charting and all that sort of thing? So if you're doing that, the first thing you should do is count the teeth. So how many teeth do dogs have? Adult, permanent teeth do adult dogs have? Any idea? Sorry? 42, that's correct. So they have 42. So if there's only 38 and it's 7 months old, there's a problem, okay? So counting the teeth is really important as a part of your oral assessment. So some of the tools that we use in oral examination, there's 4 tools that we like to use for diagnostic tools. Visual inspection, so use your eyes to visualise Periodontal probe, that's a periodontal probe. You can see it there into a pocket next to mandibular second molar tooth there. Dental Explorer, that's the sharp end on the other side of the periodontal probe. You'll see at the other end there's a little sharp. So that detects defects in tooth structure, so that's something that's really important. And then intraoral radiography, so that's Dental Explorer. So if that end is bent out of shape, get a new one, because it's not going to help you do what it's meant to do. Full mouth radiographs, we certainly do them in referral practice, and I can tell you I do a lot of the workshops for Green Cross and vet partners, and they're all doing full mouth radiographs on the first exam for any dog, any age dog or cat. I would strongly recommend that you do that once you get your units. So what sort of things do we see? So if you look at, this is Louis. Louis's got a few baby teeth retained, but he's also got 1, 2, 3, 4, 5, 6, 7 missing teeth. And he's about 11 months old. He actually came in not because of the missing teeth, he came in because that lower canine tooth was actually rubbing on the outside of his upper lip and causing an ulcer there. So that's why he came in. He's got a class 3 malocclusion. But if we look, you can see all those yellow arrows are missing teeth. That's a retained baby tooth. That's a missing tooth. That's a tooth we had to work on. That's a missing tooth, missing tooth, missing tooth. So at this age, he should have all his adult teeth. So we're going to take radiographs, which we have here. So this is a full mouth series of radiographs. You can see there's a missing second premolar tooth there. So they should have 4. So there's one missing there. So it never formed. And that's not uncommon in some of these small breed dogs, that they won't, if they've got a retained baby tooth, often there's no adult tooth or permanent tooth below it. So the arrows here will show you all the missing teeth. And that's a baby tooth there. How do you know it's a baby tooth? Well, it's got a narrower canal, pulp canal, than the surrounding teeth. And it looks like a baby tooth. It's a different sort of shape. And there's no adult tooth there. That's a baby tooth or deciduous tooth. There's a missing permanent tooth. So normally the rule is that if you see one dental anomaly in a puppy, look for others. There will be others. So as you can see, we had to extract that lower canine tooth to solve the problem with the lip problem that he was having. Also, if you look closely, that's the one we extracted. That's the one we extracted. There's a third root on that tooth there. So that's the second molar tooth. Normally it only has 2 roots. It's got 3 roots. Now, if you ever had to extract it, you'd need to know that it had 3 roots rather than 2. So that's important as well. This is plaque disclosing solution. We use this to detect plaque because plaque's invisible, so you normally can't see it, so you have to disclose it. So we're wiping it onto the teeth, and then you rinse it away, and then you basically say mild, moderate, or heavy plaque score. So you don't get too accurate with it, but you say, is it mild, moderate, or heavy? This is a calculus removing forceps. We sometimes use that to get rid of big chunks of calculus when we want to get our periodontal probe in. So that's your calculus removing forceps there. So don't use an ultrasonic scaler on that, because you'll just wear out your ultrasonic scaler. You need to remove that gross calculus before you let your ultrasonic scaler get to it. This is a walking method of probing. So what we do is we walk the probe around. Rather than trying to put it in designated spots, we just walk it around, and anything that's abnormal, we'll record. So we won't record anything that's normal. You can see this dog's got a break, a fracture there, and that little dot there is a pulp exposure. So it's actually broken its tooth, premolar 4, which is not uncommon, and it's exposed the nerve. So unfortunately, in this case, we have to extract that tooth. So with the walking method of probing, you don't tend to miss anything. The other thing we like to record is gingival index. So gingival index is a measurement of bleeding or swelling in the gum tissue. So if there's just swelling in the gum tissue, we give that a GI of 1 per tooth. If there's bleeding when we probe that area, we give that a GI of 2. Why do we record that? We record it because it tells us that there's active disease occurring in that pocket at that time. So bleeding is a sign of active disease occurring. Periodontal probe. The other thing, so normal probing depths, I was going to ask you this before I put this up, but 3 millimetres in the dog and up to 1 millimetre in the cat. And what we do want to measure is something called attachment loss. Attachment loss means the bone loss around the tooth. And so we can either do 6 probing measurements per tooth or walking method. I prefer the walking method because you don't miss anything with the walking method, and it's very, very easy to do. We do like to record, are there missing teeth? We've already mentioned that. Are there any fractured teeth? We've mentioned that. Is there any gingival recession? So you can see in this photograph on the right-hand side, this gum is receded. Now, what does that mean? What does gum recession mean? If you see gingival recession, what does that mean? It means it's got periodontitis. It actually means that the dog or cat has lost bone in that area. You don't get recession unless they lose bone. So they're not just got gingivitis, they've got periodontitis. So when we're measuring the recession, we've got to add that measurement of recession on top of the probing depth. So this is where we measure from the cemento enamel junction, that's where the crown ends and the root starts. So that's our reference point, and we measure to the gingival margin there. So that measurement there is added on to the probing depth. So just for instance, that's 5 millimetres there, from there to there, and that's 3 millimetres. 5 plus 3 is 8. So we've got 8 millimetres of attachment loss, which is significant for this tooth because this root is only going to be about 15 millimetres long. So that's over 50% bone loss around that root. So attachment loss is really important. When you're doing things, you need to be safe. So we wipe the teeth over with chlorhexidine. We used to use Hexarinse, but Mavlab make also chlorhexidine. Hexarinse is off the market for a while, but I believe it will be coming back. We like to put a cuffed endotracheal tube in and an oropharyngeal pack. I'll show you what that looks like. So there, and obviously you need to protect yourselves. Now in the States, they basically noise cancelling headphones, because when the ultrasonic's going all day, their hearing goes. So they do that. Cuffed endotracheal tube. Be careful in cats with tracheal tears. So if you're rolling the animal over, you have to disconnect it from the anaesthetic machine and then roll. And not much air in the endotracheal tube for cats. But you do need to use a cuffed tube in cats because there's a lot of water in their mouths when you're doing the clean, and that can go down into the airway. So what we normally do is I just use gauze, and I tie a length of gauze to a rolled piece of gauze, and I pack that into the back of the throat. That picks up any debris such as calculus, bits of tooth. So sometimes you lose a tooth that you're extracting, so it'll go into that. So just protecting the oropharynx. Even if it gets wet, it's still protecting from hard tissues falling into the back. Now you may have heard of something called anaesthesia-free dentistry. Have you heard of that? It's where certain people are doing teeth cleans on dogs, mainly on dogs, conscious. So they're actually using scalers, not ultrasonic, but hand scalers to scrape plaque and calculus off the dog's teeth. And it has got it's got a number of issues. There's a welfare issue that you can hurt the animal with just scraping, and the second problem is it's only cosmetic. It doesn't actually treat the disease. So you may hear about it sometime in the future. Just be wary that sometimes certain places are doing it, such as grooming parlours and so forth. So what's the importance of an endotracheal tube? Well, obviously for this guy it's pretty important, and it's a bit longer than what we use in dogs and cats. And he's only using a dog laryngoscope, but and no cuff. Oh, he's got a small cuff. Yeah, small cuff for big cats. Yeah, goes all the way down, and it's better that he's under a GA for all this. Okay, one of them woke up during in recovery before they got it into the cage. We ran, but the keepers there, they didn't run, they dragged it back into its cage before it really woke up. So this is an oral exam under GA.
We look at the soft tissues, the tongue, the tonsils, the mucosa, the gingiva, and also the hard tissues, the maxilla, the mandible, and also the teeth and the surrounding of the teeth. Here's the oropharynx. We're looking at the tonsils and the
same dog from the conscious.
I like to count the teeth first to make certain there's no extra teeth or missing teeth. As you can see, there's missing incisors and canine tooth in the upper there. We also like to check for any damage to tooth structure, attrition, abrasion, or any erosion. We place a pharyngeal pack at the back of the throat to protect the oropharynx. Here we are looking at the soft tissues of the tongue, the ventral tongue, the dorsal of the tongue. We're painting a plaque disclosing solution on here to demonstrate plaque, so we'll apply that to all the teeth, to all surfaces of the teeth. This dog hasn't got a lot of plaque, so this will be a plaque score of about 1+. We also will look at calculus. So this dog has got some heavy calculus, about premolar 4. So we'd call this about a 2+ calculus score for the whole mouth. We're just removing some of the calculus to make periodontal probing easier for us. As I said before, we'll look for any tooth wear. Here we have some reparative dentine, tertiary dentine. There's no pulp exposure, so we're using the Sickle Explorer to probe for any pulp exposures there. And we'll do that for all the teeth. You can see that there's significant bone loss around the mesiopalatal root of the 108. Then we'll use the walking method of periodontal probing. So we walk the probe around. Anything above 3 millimeters is abnormal. If there's any gingival recession, that will also be recorded. This dog's pretty good in most areas. There was some deep pocketing in some areas. You can also see around the maxillary first molar tooth there, there's a furcation involvement of about 1. And we're just coming around onto the palatal sides. Also probing on quadrant 4 on the labial side. This is a little bit speeded up. So we'll measure all surfaces of the teeth. We can also use a mirror and the probe. There's a 5 millimeter pocket on the lingual side of this tooth, 306, and that tooth actually will be extracted. We're also probing around the first molar tooth, 309. You can see there's some tooth wear there. Here's quite a deep pocket, a 6 millimetre pocket between the 301 and 401. Here's a 9 millimetre pocket involving teeth 201 and 202. Here we have an exophytic mass, a gingival mass.
That's a tumour.
404 that needs to be biopsied because that is abnormal. You can see we've probed around that tooth. There's about a 5 millimetre pocket there, which could be a pseudo pocket due to the mass. We'd like to take radiographs in the cohort, so we do a full mouth series of radiographs. I've just given you some selected radiographs coming up shortly. This is a view of quadrant 4 and the incisor teeth. You can see there's over 50% of bone loss involving 301, 401 and 402. These are the deep pockets that are palatal to teeth 201 and 202 that we showed you in the photograph. Here we have some uncomplicated crown fractures of 408, 409 and 410. And we finally follow up with a dental chart and record all our findings on the dental chart.
So just looking at how you grade the level of periodontal disease, obviously if the probing depth's less than 3 millimetres in dogs and less than 1 millimetre and there's no bleeding, no inflammation from the gum, then that would be considered normal so long as there's no gingival recession. Then we have a grade 1, which is basically gingivitis, so we'll have gingival inflammation. You can see along the margin here it's red, but we'll still have normal probing depths and no recession, so that's gingivitis. Now, do you guys do the teeth cleaning yourself, or do the vets, or sometimes you do it, sometimes the vets does it? Okay, so you guys are, if you're Cert 4, you're qualified to do it. It's just a matter of getting someone to allow you to do it. But you are qualified to do it. I'm giving some lectures in Perth in a few weeks' time to vet nurses, and they're allowed to do simple extractions as well. That's a bit of a contentious issue. They're also allowed to give local anaesthetic nerve blocks as well, which is also contentious because a lot of vets don't do that very well. So, yeah. So anyway, we'll see what they're like. So this is gingivitis. So once you get into grade 2 disease, then we have bone loss. So you can see there's some recession here, so that has to mean we've got bone loss. There's a little bit of recession here. So, or the probing depths are less than 5 millimetres, or we have something called furcation bone loss. Do you know what furcation bone loss means? Furcation bone loss means you're losing bone between the roots of multi-rooted teeth. So we'll show you what that looks like on a radiograph. So grade 3, so this means they've lost between 25 to 50% bone around their teeth, or they've got furcation bone loss of 2, or they have pocketing of 5 to 7 millimetres. You can see there's recession here. There'll be furcation bone loss there, so you can actually put a probe in between the mesial and distal roots here. There's furcation bone loss there. And then we get to the final stage, which is grade 4, where we have through and through furcation bone loss there and there. So that's class 3 furcation, greater than 7 millimetre pocketing, and that means that we've got over 50% bone loss. Now you may think that, okay, dogs, pretty horrible mouths, okay? Cats, some of them can have horrible mouths, and I'll show you a dog with a really horrible mouth sometime in the future in this lecture, but humans get horrible mouths too. So yeah, it's not nice, okay? And often in these situations, being a human dentist, often it's the calculus that's holding the teeth together rather than anything else. So this is what we would see on a radiograph. Another reason to take radiographs. So you can see there's bone loss in between those roots, there and there. And that goes through the stages or the grading of disease. The Americans call it staging, we call it grading. But I want to point out a couple of things here. So you know that just by looking at that radiograph, you would assume that this tooth needs to be extracted. Would that be a fair assumption? Yes? Okay? Yes, and I would agree. It's got over 50% bone loss, especially around that distal root. But there's a couple of things there that worry me during the extraction. One is if you look closely at the end of this root, it's got a right angle turn on the root there. So it's going to fracture there if you don't know that it's got that. And number two, can you see this shadow that's over about the lower third of this root? So you see how it goes. So look at the tooth structure there. The density of the tooth structure on the x-ray looks okay there. Then it goes a bit darker and then it goes a bit lighter. Everyone can see that? Okay. So what that means is that darkness is the mandibular canal. So that's the canal that runs in your mandible where the nerve runs. So what that means is that that canal is overlying the root of that tooth. And if it's overlying the root of that tooth and you fracture the root about there and you start digging, you may push the root into the canal. And if that happens, you get a lot of bleeding. No bleeding, and then all of a sudden there's a lot of bleeding because you push the root through the nerve and the neuro and the blood vessels in that. So preoperative radiographs are really important in picking up, are there any things that we need to worry about before we extract the tooth? So the sorts of minimum recording that we like is the occlusion, missing extra teeth. We grade the disease based on probing and, unfortunately, dental radiographs. We do a gingival index per tooth, plaque and calculus score for the whole mouth usually. So we've got the probing there, gingival recession, furcation, fractured teeth. Are there any fractured teeth? And UCF stands for uncomplicated crown fracture. CCF stands for complicated. So we need to know, is the nerve exposed in the fracture or not exposed? And then teeth that have lost a lot of bone around them will become mobile. So we need to know, are the teeth mobile? So this is sort of a pretty simple sort of chart where you have a pre-treatment and a post-treatment. You may not realise that with the top of this and the bottom of it, you've got the teeth flattened out across there. That's so you can draw in the recession. So you can actually draw a line where the recession is. And you need to record the recession and add that onto the probing depths because that's attachment loss. So attachment loss is important to measure because it tells us how much bone has been lost around that tooth. This is all on this website. So if you go to the avdc.org, you'll see all this sort of stuff on the website. There's more involved things such as these. You can talk about pocketing, gingival recession, fillings, endodontics. So there's more involved charts as well. This is sort of the mainstay of dental cleaning. This is the IM3 unit, which is an ultrasonic scaler. I don't know what units you have, but this is a very commonly used one. Do you know much about how they work? They work by, number one, the tip moves, in this case, in the IM3 unit, moves at 42,000 times per second, which is fast. I'm not going to demonstrate that for you. But what it does do, it does this. So you get water bubbles forming on the tip, and those water bubbles get larger and larger and larger, and then they explode. And when they explode, they release energy. And when they release that energy, it breaks open the bacterial cell wall. So the bacteria die through that energy release. So that's how they work. They do have something called acoustic microstreaming as well, which means like a fast-flowing river in the middle here, but on the shores, on the banks of the river, there's little circular eddies forming, and those eddies wash away the debris. So that's what that is meant to be. The other thing you need to know is that if the tip of your ultrasonic scaler is worn, then it doesn't work very well. and at least with the IM3, they give you a guide to put up against the tip, a one-to-one guide, and you hold it against the tip and it tells you where the tip is worn. Because if the tip's worn, it doesn't work. And usually you don't get a fine spray on the end of the tip, so you normally get a fine mist of water hitting the tip. If it's worn, you get droplets of water forming. And if droplets of water form, that means the tip's worn. The other thing that you may or may not know is depending on whether it's the IM3 unit or another type of unit, you've got to change the power setting when you go very deep. So if you go beyond 3 millimeters in the dog, you've got to turn the power to half. Or if it's the IM3 unit, you put it on 3 lights, because you don't want that tip hitting the root too vigorously, because it can damage the root. So we turn it down to 3 lights for the IM3 unit. For other units, you'll have a dial. You'll turn that to half or below, just below half. The way we clean, this is human, not a human tooth, but a premolar 4 in a dog, but we go, it's called down the elevator up the stairs. So the tip goes down to the pocket, the depth of the pocket, and then it's walked back up the stairs to clean the sides of that pocket, of the root of that tooth. So down the elevator, up the stairs. So this is ultrasonic scaling. So you've got to keep the tip moving. You don't want to spend more than about 10 seconds per tooth. So if you haven't cleaned it, come back to it. And you can see the tip runs subgingivally, and you want to clean the plaque and calculus that is subgingival. So you just keep on working your way around. We hold it in a C grasp. That's a C grasp. And our little small fingers are resting on something to give us better control over the tip. So you use the flat of the tip as well. Not the point, you use the flat of it. So when we polish,
finally, we'll use a polishing paste in a polishing cup. Always have paste in the cup so that the cup doesn't overheat. And we can flare the cup to clean subgingivally. So polishing will help remove stain and also will remove extra plaque. Thank you for watching this video.
Sorry, I just... so it doesn't polish the tooth surface. So there's a misinformation to say if you polish the tooth, plaque can't adhere to it. That's wrong. If you polish the tooth, you just make it polished and you get rid of stain and you might get rid of more plaque. But it doesn't make the tooth, it doesn't stop plaque from being able to attach, because plaque attach by something in the saliva called the acquired pellicle. Now there is a product out there in the home care range that you may or may not have heard of that attacks or breaks up the acquired pellicle. So it actually tries to stop plaque from adhering onto the tooth surface. Does anyone know the name of that product? It's a home care product in dogs. Oravet. Yeah, so Oravet attacks the acquired pellicle. So Oravet's not antibacterial, it stops the acquired pellicle from forming on the tooth. So it works in a slightly different way. And the yellow bit in the center of the chew, that's the dalmopanol, which is the active ingredient. So the dog can't, if the dog swallows the chew whole, it doesn't get any of the active ingredient. It has to chew to get to the active ingredient. Oh, did I miss something? I don't know if you guys do before and after photos, but it's quite popular. And it's great to show the clients what you've done. And it's great also if you're grading disease, you can actually have a library of dogs with grade 1, grade 2, or grade 3 or grade 4 disease, so that when the client brings in a dog that's got a grade 2 disease, you can show them what a grade 4 will look like if the owner doesn't do anything for the dog. So it's quite a powerful tool for that. So we take lots of photos in referral practice. It's very common, and we'll do before and after photos if we're doing cleans as well. So try, if you can get it, I know life is very busy, but it does help if you can get a photo that you can show. And a lot of clinics will print this off for the clients, so they have a hard copy of it as well. That's the Orovet brochure. I don't know if you've seen that, but it goes through the different stages of periodontal disease and what it looks like on radiograph and what it looks like after you've done the clean or whatever extractions and so forth. Have you seen that at all? Yeah. A colleague of mine and myself, we did that for Orovet, for their this brochure. So what part of home care advice, home care is a part of the COHAT. So you need to talk to, so do you guys talk to the clients about doing home care? Is that your job, part of your job? When do you do that? When you're discharging the animal, you try to do it at a recheck when you're checking to see how everything's gone from the clean or the extractions and stuff like that. Probably not a good idea to do it at discharge because the owners aren't really interested in hearing that sort of stuff at discharge. So you try to do it at another time. There is a big call in vet, and I do a lot of workshops for private practices where they're doing nurse consultations now. So are you guys doing nurse consultations? Yes, some of you are. So nurse consultations are where you do the preliminary stuff, TPR, history taking, that sort of stuff, and then the vet comes in to look at all that and then formulate a diagnosis. Now, owners need to know, the important thing from this slide is this. I call it the 30-70 rule, you can call it whatever, but what it means is, as professionals, what we do for their pet is about 30% of looking after periodontal disease. What the owners do at home is 70%. So the reason we say that is that the owners have to take responsibility for the home care. And they can't just leave that and expect that the animal's going to be fine if it has a teeth clean every year, because it won't be. It needs to have home care performed on it on a regular basis, usually daily. Can you do, sorry, I slipped a slide. Can you do home care? I don't know if this will play. Let's see. No. I'm going backwards. So you can brush cats' teeth. If you start young, that's the best way. Dogs, cats, start young. A bit like children. Start young, get them used to something being in there. I know it's difficult, but you've got to start young. So we'll just put up some oral pathology examples in the last few minutes. So, okay, so what's that? There's a bit of brown stain on that canine tooth. Is it just stain? How do you know if it's stain? Well, it should polish off if it's stain. It could be, but that's enamel hyperplasia. So it means the enamel hasn't formed properly. And you can see on radiographs, not the same dog, but on radiographs you can get these indentations in the tooth. This is a young dog. How do you know it's a young dog on the radiograph? Look at the root. The root's really thin and the end of the root's open. So it means this tooth is still developing. That's why trying to extract a canine tooth in a 6-month-old dog is quite difficult, because the root fractures. So this dog's got enamel hyperplasia. This one's got one in the mandibular canine. You can see that it's also got another problem up there, which you can't really see, but it's got a lance, so it's got no room for that lower canine to go in between the canine there and the third incisor. That's why it's pointing outwards. But I dare say that possibly this puppy had its deciduous canine removed when it was 8 to 12 weeks of age, and that can damage the permanent. So when you try to take out a baby tooth in an 8, 12-week-old puppy which you sometimes have to because they're hitting the hard palate and causing a lot of pain, then you've got to be careful that you don't damage the adult tooth, and that's one of the things you can see with damage to the adult tooth. So we always recommend, we warn clients about the risk of damaging the permanent canine tooth when we try to extract the deciduous canine. That's really important, and you've got to be careful where you put your elevators. You can't put an elevator onto the lingual side, the medial side of the deciduous tooth, because imagine that tooth still in the bone, you can damage that tooth before it erupts. And we see enough of that, unfortunately. This is another one. So what's that there? It's probably not that clear, but that's a hole in the gum tissue. So we call that a parallus. You can also see, what about this tooth here? Does that look a bit abnormal? It's got a fracture and it's got a pulp exposure. So the nerve's exposed in that one. How do you know? Well, under GA, you can probe that and the probe will go into that hole. You can also work out where's that. So that's telling you you've got infection draining from somewhere. You would assume that it's draining from this tooth, which is a good assumption. Most of it is, but unfortunately it's also causing other problems. So we put a little marker in there into the draining sinus. So that's a little marker that basically shows up on X-ray, and we push it in until we can't push it in anymore, and it goes into the hole in the gum, and it points to the tooth or teeth that are causing the problem. So when you take the radiograph, you can see that the problem isn't just that tooth, but it's also that tooth as well. Because there's a huge bone loss in this area associated with that tooth. You can see the fracture here on the X-ray. All that's bone loss in that area, and it's also working its way around this tooth. So unfortunately, to solve this dog's problem, you've got to take out that tooth, which is that one, and the one behind it as well. You've got to take out 2 teeth, which we did. And that's the probing. So we also had bone loss in between those 2 teeth as well, associated with that. So that broken tooth with the nerve exposed caused that and the infection around this tooth as well. I put that up before. That's that dog that we put up. So this is a poodle with stomatitis. It's got ulceration along its tongue and ulceration here around its premolar and molar teeth. And that's the radiograph, and you may see it a little bit more clearly now. There's a right angle turn to that root. Even the fly can see it. And you can also see the shadowing there. You can also see, if you look at this root, and you're going to be taking this root out as well, and you fracture the root here, again, you can push that root into the canal because there's no bone underlying or overlying the canal. That root can be pushed into the canal. This is a dog that, if you looked at its mouth, it's 2 years of age, chews on tennis balls, chews on other things as well, but chews on tennis balls. It's got a missing tooth here. It's got a little fractured tooth here, but doesn't look too bad. You'd look at that and say, I'm just going to do a clean on that. That's fine. Looks okay, but when you take the radiograph, this is the radiograph. That root, that tooth there, there's no root there. So that tooth will be mobile. If you feel that, that crown will move. This one has got about 50% of its root missing. This one's got about 50% of its root missing. This one's got about 25% of its root missing. This one's got some early signs of resorption. So you can see that the ligament here dips in. That root should sort of come down there, so it's losing some of the root. This one's got about 75% of its root missing. This one's about 75%. But you look at that clinically and it looks okay. So we're seeing a lot more dogs now with tooth resorptions. And unfortunately, some of these teeth will need to be extracted on the day, like that one, and that one. We may monitor these but certainly 3 teeth would have to, so that one, and that one. This dog had other issues, but we feel that the tennis ball, the chewing on tennis balls puts pressure on the ligament that holds the tooth in place, and that damages the ligament, and then when the ligament is damaged, cells come in and start destroying the tooth. So that root should be about there. That's where it used to be, down there, but it's been resorbed completely by about 50%, at least on that one. This guy had other problems. He's had root canal on this tooth that we were doing. He's missing a tooth here and he's missing one on the other side because he's a blue heeler and he attacked a operating chainsaw. So he basically bit into a chainsaw when it was working. And the dog didn't come off very well with that. Cats, if you look at this photograph here, you can see, so cats with tooth resorptions, they're going to have little indications they've got a resorption going on. So if you look at this tooth here, you follow it around, gum looks a little bit red there, but it looks really red there, and there's a little bit of redness there around that area. So what happened is this tooth was extracted, but not all of it, and the x-rays weren't taken, so they had no idea what was going on with that tooth. And on the x-ray, this is what was happening. So that tooth is that tooth. So you can see the root and the crown of that tooth is being destroyed by tooth resorption. And this cat had pain, so it had oral pain, and that tooth there is causing a lot of its oral pain. But if you didn't take a radiograph, you'd have no idea. And also that's part of the root. There's root retained here, which we had to take out as well. These are some examples of some tumours. So if you look at, that's lower jaw, around premolar 4 in the upper jaw, and around premolar 3 in the upper jaw. They all don't look too dissimilar. You know, that one might be a little bit ulcerated. That sort of looks a bit like that. They all look pretty similar, but they're different tumours. So these ones are called acanthomatous ameloblastoma, so they invade the bone. So they actually eat into the jawbone in that area. This one doesn't, but you still have to take a reasonable margin. This one is the same, it's eating into the jawbone. So this one you've got to take at least a centimetre margin around it, this one a centimetre, and this one you'll get away with 4 to 5 millimetre margin around it. This one, you'll be into the nasal cavity of that dog, because when you take the margins, you'll be into the nose. So you just need to know, so we always, really important that you take incisional biopsies. A biopsy, get your vets to take a biopsy to see what they're dealing with, because sometimes you can't tell just by looking at them. I mean, this dog presented to emergency. I used to work at University of Melbourne as well, teaching there. This dog came to emergency at Melbourne Uni because it had oral bleeding. It was a German Shepherd, so you thought maybe it's a clotting defect, so they checked for that. Couldn't see any clotting issues. But if you looked at its mouth, it looked like that. Really red, inflamed in that area. But the thing was, it wasn't symmetrical. That wasn't like that on the other side. In fact, that's the only area that looked really red and inflamed. So when you see that, a little light bulb goes off in your head or a little red flag gets waved to say that's not normal. And so this dog ended up having a squamous cell carcinoma in its nasal cavity that invaded from the nose down into the oral cavity. So that's where the bleeding, so all this area was bleeding because of the invasion from the nose. This guy, Frank, 8-year-old Shih Tzu. Owners can't afford much, and what can be done? So that's not Frank, but you'll see hasn't really got a very nice mouth. So that's So what they did is they anaesthetised it, they cleaned all the calculus off, and that's what they saw, okay? I don't think you need x-rays to realise that most of the root's sticking into the mouth there, no bone around it, okay? But they were worried about, so they rang me while they're doing this. They're worried about this area. So we'll get to that area soon. So that's his other side. Pretty similar. So symmetrical, you'd say, pretty similar. These are some of the radiographs that are scary. So not much bone in this area here. So the risk of jaw fracture is very high in this dog. If you're trying to take out these diseased teeth. But they're more worried about one other area. I'll show you that. So you can see, again, the upper jaw on the right-hand side, not much bone holding those teeth, but those little arrowheads there are telling you that the ends of those roots are very close to the nasal cavity. There's hardly any bone between that root and the nasal cavity. So again, the risk of going into the nasal cavity is reasonable there. This is one side, that's the right side, but they were worried about the left side, and for good reason. The left side was bad, but you can see there's no bone around that tooth. So this dog may already have a jaw fracture before you even start. Now, if you don't take a radiograph and you don't realise that it might already have a jaw fracture, the jaw will break on you or whoever's taking the tooth out. So just be aware that it's important that you take a preoperative radiograph before you pick up any instrument and start digging around. And I think I finished 2 minutes late, but apologies for that. Okay, that's sort of a whirlwind tour of cohat. So now you at least know what a cohat is. Any questions from any of that? No? No? No?
What stage, like if someone can't afford to have extraction or they don't want extractions, like what stage of periodontal disease and like bone loss?
I think if it gets into a furcation of 2 or 3 or grade 3, grade 4, you're looking at either at least 6 monthly cleans to try to, they have to do active home care, so they have to brush daily. If they're not willing to do that, you're wasting everyone's time. If they are willing to do that, you can save any tooth if they're willing to do something, but usually it'll mean at least 6 monthly professional cleans on top of the daily brushing, and then reassessing it every 6 months to see if whatever we're doing is working. I mean, you can do bone grafts and things like that, and what they call guided tissue regeneration, but they don't work very well in dogs if the owner can't do, and I'm not just saying good home care, they have to do excellent home care. Basically brushing every day, brushing the areas where a lot of the disease would be. We take out, so if we have incisors that are affected, so I'll just go back to this guy. Okay, so if you had got this guy earlier on, say, you can see there's well over 50% bone loss around those canines. But if we had got them earlier and there was less bone loss around those canines and there was disease around these incisors, we would take out the incisors. We take out the incisors because it's easier for the owner to clean around the canines if there's no incisors there. And often in these small breeds, all their incisors are crowded up, jammed together, and they're really good. They're like a plaque magnet. Bacteria just love it. And you can't get rid of the plaque. So we would do that. We try to save important teeth, such as the maxillary premolar 4 and the mandibular first molar. We try to save them if we can. But when you get, furcation bone loss, like, that one, you got to work backwards for these. So you got to work out what can the owner do to keep that area clean. You can clean that professionally with your ultrasonic scaler, but how do they keep it clean? And to tell you the truth, unless they're sticking a little interdental brush in there every day, like people do, they're not going to be able to keep it clean, and it'll get worse. And then you'll end up that going to that, and then their jaw's going to fracture. Not only just one side, both sides are going to fracture, which is a real nightmare when that happens, because you've got a lot of disease there, and trying to get a jaw to mend in an older dog with lots of periodontal disease is really quite difficult. So you can save teeth, but you've got to be realistic about it, and owners have to be realistic as well. But you need to be able to have that conversation with them so that they understand what their responsibilities are as well. We get people that laugh at us when we say you've got to brush your dog's teeth. So you know where they stand. Automatically they're saying they're not going to do it, okay? All right, any other questions?
Like with full mouth extractions, like is there anything else you can do for them afterwards?
As in implants or?
No, like does their chewing and all that affect muscle?
They'll get a bit of muscle atrophy, they'll get bone loss. So these guys, they're already losing bone, they'll get a lot of bone loss because the teeth aren't there. But, you know, dealing with humans as well, there's enough people out there that don't even wear dentures that eat. They'll eat soft food. So these guys will have to eat soft foods. We get some of them that can actually crunch dry food between their upper and lower jaws. But on the whole, they're going to be eating softer food, and they're not going to digest it as well, so you have to be careful with gastrointestinal upsets and things like that. But it's better that they don't have any teeth when they look like that, okay? Because that would be heaps of bacteria entering the bloodstream all the time, and they would be causing problems elsewhere in the body.
When probing the teeth, if you're probing, your four-quadrant tooth, or doing that walking method, at what point do you take out the tooth if it reaches a depth greater than 3 millimetres? Do you just? So
up to 5, you're okay. Yeah. Between 5 and 7, it's questionable. Above 7, it means normally for most teeth above 7 means they've lost over 50% of bone. So yeah, so that would be. But unfortunately, it's not always as simple as that. Some of these dogs will have gum recession on top of, so you might get 4 or 5 millimetres of probing, but they may have lost 50% of bone around the tooth just from the gum recession. So you've got to work that out as well. And unfortunately, radiographs do help you make decisions. The probing is important, it's very important, but without the radiographs you can't put 2 and 2 together. You've got to match the probing with what you see on the radiograph, and with this sort of situation, the referring vets weren't going to touch that tooth, because that jaw, they'd rather have me break the jaw than they break the jaw, okay? But to answer your question, above 7, impossible really for the owners to clean. You can clean it professionally, but they're going to not be able to clean it, because your toothbrush goes down under your gum about 2 millimetres at the most. So they're never going to be able to clean. Even if you get healing in a 7 millimetre pocket, you might reduce it to 5 millimetres, then they're going to be missing 3 millimetres of that pocket. Whereas if it's a 5 millimetre pocket, you may get 2 millimetres of healing, so they're getting close. So it's all based on what you do professionally, but a lot, as I said before, on what the owners can do, because unfortunately there's no easy solution for this. They can't get away, they can't put a little water additive in their drinking water and think that's going to solve the world, or they can't give it Hill's TD all the time and that solves the problem as well, because it doesn't. Okay, all good? That's okay? Yeah.